So welcome everyone to our Your Child's Health University lecture this evening. My name is Felice Stonestrom and I manage the community programs at Stanford Children's Health. And just as a reminder, we are videotaping our lecture this evening, so we ask that you please silence your phones. And if you have questions, if you would hold them to the end, at which point we will turn off the cameras and you can ask your questions anonymously. So our lecture this evening is titled Bulimia and Binge Eating in Teens, What We Know and What to Do. And we're honored to have two speakers tonight, Dr. Kara Fitzpatrick and Dr. Shelley Aggarwal. Dr. Kara Fitzpatrick is a clinical assistant professor in the Division of Child and Adolescent Psychiatry at Stanford. She attended Ohio State College of Medicine in Ohio, completing her internship at Nationwide Children's Hospital in Ohio, and then a fellowship at Stanford University School of Medicine. Dr. Fitzpatrick's current research focuses on neuropsychology and neuroimaging in eating disorders. She is particularly interested in the role of weight suppression and malnourishment on cognition, the evaluation of neuropsychological deficits in adolescents, and cognitive features associated with obesity. Dr. Shelley Aggarwal is teaching faculty at Lucile Packard Children's Hospital at Stanford University, as well as University of California at San Francisco Fresno Division of Pediatrics. She's a board-certified pediatrician and adolescent medicine specialist. She has worked and practiced in a variety of clinical environments, including various international settings, and is actively involved in adolescent programs related to nutrition, disordered eating, underserved youth, and general adolescent care. Her areas of interest include wellness, mindfulness, preventative health, and applying integrative principles to assess and treat teens and young adults within a holistic model. Thank you very much both for coming.
Good evening. I'm Dr. Fitzpatrick, and I'm going to be starting off our day, or our evening, I guess, and really covering what it is that makes up bulimia and binge eating disorders and what we think we can do about them. I do have some disclosures. I am actually paid to train people in the treatments, some of the treatments that I'm going to be talking about as empirically supported treatments for bulimia and binge eating disorder. Over the last 10 years, there's been significant advancements in the treatment of eating disorders, especially for children and adolescents. What we've seen is not only changes in treatment, but also changes in diagnostic categories. And so we're going to be talking tonight about what makes a diagnosis. How do you know someone has a specific issue or challenge? And also what we can do about that in terms of psychological and psychiatric treatments. My next slides are really boring because they're actually going to cover the diagnostic criteria for bulimia and binge eating in some depth. In fact, exactly the way they are written for psychologists and psychiatrists. So bulimia nervosa is characterized by recurrent episodes of binge eating, where a binge really requires two things. The first is eating in a very discrete or short period of time an amount of food that is definitely larger than most individuals would eat. We sometimes refer to this as a gross amount of food or a very large amount of food. And often it's not specific foods that someone is looking for. Someone may start eating, say, a sandwich and begin eating a variety of foods and even sometimes non-food items or condiments like ketchup or cocoa powder. For some people, they also don't eat quite as much, but they feel, the second part being the most important part of this definition, a loss of control. They can't stop themselves from eating behaviors. And so it's this loss of control that's actually critically important in defining a binge eating episode. You're not able to decide how much or whether or not you can stop. And people often only stop eating when they either reach a point of fullness that they literally cannot eat anything more, or because they run out of food, or someone catches them, or they're stopped in another way. And it's really important to note this because that loss of control is extremely distressing. All of us like to have a certain amount of autonomy and independence in what we do, and losing control really changes that game for people. The next thing that happens with bulimia nervosa are what we call maladaptive or inappropriate compensatory behaviors. In essence, what happens is the individual is so afraid of weight gain from their binge eating episode that they begin to engage in behaviors that are thought to lead to weight loss, or one might think about it as negating the food that they just ate, sort of erasing the eating episode. The most common type of purging mechanism that people talk about is self-induced vomiting, but it's really important to note that there can be other ways in which people can purge, including the use of laxatives, things that make you poop, diuretics, things that make you pee, herbal supplements or other types of medications, as well as fasting. So going on a juice fast or a cleanse after a binge eating episode would also be a maladaptive strategy for losing weight. And finally, excessive exercise. And it's really important to note that what becomes excessive may be categorized under two areas. One is compensatory exercise. I ate this amount of calories, so now I'm going to exercise to burn that amount of calories off. It can also be compulsive. I'm unable to stop myself from engaging in exercise, and I engage in exercise even under risk of injury or under less than ideal circumstances. I had a patient tell me recently about running in the hail, and she didn't want to be running. She knew it wasn't appropriate, but she couldn't stop herself from doing that. In addition, because these behaviors actually occur with fair amount of frequency in the population, you can't just have these behaviors, although personally as someone who treats eating disorders, I would be worried about any level of these behaviors. To meet criteria, you actually have to engage in these behaviors on average about once a week for 3 months. Again, like I've said, this is in order to meet criteria for this. The other aspects of this disorder have to do with the way in which we evaluate ourselves and the ways in which these symptoms interfere with us in our regular daily living. For self-evaluation needs to be unduly influenced by weight and shape. And I want to take a moment here and say body image dissatisfaction and people being uncomfortable with their body or not liking parts of their body is actually, unfortunately, far more common than body care or body enjoyment. Almost all of us experience some level of body image dissatisfaction. What's important here is that the idea of how I look actually influences how I feel about myself, what I feel I'm capable of doing, the amount or types of activities I'm willing to engage in. And so we find that fears around weight gain, and eating behaviors actually stop the person from developing in a way that we might think of as useful, healthy, and effective. Finally, these behaviors can't occur in the context of anorexia nervosa. And this is a common misconception that people who engage in inducing vomiting have bulimia, and that you have anorexia if you don't do those behaviors and you simply exercise. But actually, the difference between the two disorders has to do with how much you weigh. So our patients who have bulimia nervosa are at or above a normal body weight. So you can't look at someone and tell that they have bulimia because their weight is in range. You can have these exact same behaviors, but if your weight is artificially suppressed or you're below weight, you'd meet criteria for anorexia nervosa. What you don't get is both at the same time. One of the things that's changed is we've started adding what we call specifiers, or ways of understanding where someone is in the trajectory of their illness. And this is actually really beneficial to people who are seeking treatment, because this actually allows us to continue billing for this disorder, and it's a parity diagnosis, so that makes it even more fundable by insurance. And so you can be designated as having partial remission. You've met full criteria for bulimia nervosa in the past, but currently you're doing better with symptoms, and you wouldn't meet full criteria, but you'd be in partial remission. And then also in full remission, which means that we've begun to recognize that the absence of symptoms may not mean that someone is completely well, and we may need to continue treatment during a period of symptom abstinence in order to help someone get completely well. One of the other big changes is that we've added measures of severity. And this is a terrible slide, and I really apologize. But severity is really based on the number of episodes of your inappropriate compensatory behavior. In other words, how often you may be using vomiting, laxative use, diuretic use, in order to erase or negate a binge eating episode. And so you can see from these numbers, they range from mild to extreme. And what's actually fairly typical when people present for treatment is that they're already following in the moderate to severe range. And so these behaviors are much harder to identify than people typically think that they are. What we see in presentation also is the number of different types of purgative methods that someone's using is also indicative of the course of treatment and the likelihood of reaching full recovery. The more maladaptive behaviors you're using in order to lose weight, the harder treatment's going to be. And that makes sense to us because we think about each of these as separate treatment targets, things that we need to identify. Now, that's bulimia nervosa, and bulimia nervosa has been codified in the literature since the 1980s, and actually treatment came about that quickly. So less than 6 months after we created the diagnosis of bulimia nervosa, we had treatment for it. But binge eating disorder is actually a new disorder. It became a full-fledged disorder in the most recent iteration of the Diagnostic and Statistical Manual. And it's been the subject of a fair amount of controversy, but also a fair amount of research. So binge eating disorder is the presence of recurrent binge eating episodes. The binges are described exactly the way they are in bulimia nervosa. But the difference is that they're associated with 3 or more of the following. And I'm going to go over these, but I will say that there was a very interesting New York Times op-ed piece that was written by a fairly famous psychiatrist right after we proposed these criteria. And he said, well, everybody does this. And I think at least myself and several of my colleagues, we all sort of sat back and went, really? And it tells you that there's this belief that binge eating is actually fairly common. Sometimes people refer to Thanksgiving as binge eating day. But in fact, binge eating by itself is very different than typical eating. What most of us do when we think that we might be binging is deliberate overeating. I go out to eat and my food is really good, and I went to Cheesecake Factory and it's a portion for like 3 people, but it tastes good and rice doesn't reheat really well, so I'm going to eat more of it than I intended to. Sometimes we might accidentally overeat. There's a lot of food in front of us in a chip bag and we just keep eating, and we meant to eat a serving size. 7 chips is a serving size. Does anybody ever just eat 1 serving of chips? No. And so we accidentally overeat. A binge, however, in addition to that loss of control, can't stop yourself. People tend to eat much more rapidly than normal. They might not even fully chew their food. And as Americans, we're not really great at chewing our food so well anyway. But they're also eating until they are uncomfortably full. So full that many people feel that they have to vomit or otherwise get rid of the food because they're actually in pain from the amount of food that they're eating. Some people spontaneously regurgitate because they simply can't put any more food in. And then they're also eating large amounts of food in the absence of hunger cues. Anybody who's gone grocery shopping after a long day of work where they're really hungry will find that they actually increase the amount of food that they're putting in their cart, or they might serve themselves more at their next meal. But this is actually eating even when you're not hungry. It's serving a different purpose for this individual. And there's also eating alone, often for fear of being judged, humiliated, or embarrassed by the amount that one is eating. And afterwards, people feel very disappointed or disgusted, depressed or guilty or ashamed. Many people go to great lengths to hide their eating behavior so that other people don't know how much they're eating, where they're eating, or what they're eating. So what we see in binge eating disorder is there are these periods where someone eats out of control. And one of the things that's really interesting about binge eating disorder is it begins at a younger age, apparently, than bulimia nervosa does. Bulimia nervosa tends to have an onset between about 16 and 18 years of age, so it's a little bit later in adolescence, but can onset at any point in time in the lifespan. We begin to see binge eating episodes as early as late childhood for some people, and again, it can onset at any point in time across the lifespan. So there isn't a discrete period that we look at for this oncoming. But for some people, it begins as an emotional eating. So when you guys have had a bad day, what kinds of things do you say, oh, I've had a bad day, I'm going to go home and have some comfort foods? What kind of comfort foods do you guys think about having? This is actually where it's participatory. Chocolate? Cake? How come nobody's like, what? Pasta. Nobody's like red bell pepper slices. No? Crudités, a little bit of broccoli. No? The reason why is a lot of the times what we're looking at for emotional eating are foods that are high or rich in carbohydrates, sweet, yummy, rich foods. And we call those comfort foods because, in fact, they produce serotonin. So when we eat them, they actually produce a neurohormone or chemical that's used in the brain to stimulate feelings of wholeness, wellness, well-being, and lack of depression. So the risk often is that the kinds of foods that are binged upon, both in bulimia and binge eating disorders, are ones that actually have a high emotional salience value. They feel good to us to eat, they're very rewarding, they're tasty, they're yummy, and they impact our neurobiology. Sometimes, and I find this to be true more in girls than in boys, although boys' athletics sometimes has this aspect too, is a very social aspect to binge eating episodes. I certainly know that when I was younger and still had sleepovers with my friends, and actually even now when I have sleepovers with my friends, we tend to have a high amount of junk food at home. And I remember when I was in my teens, we would, bake brownies and then eat the whole pan, and we didn't think anything of it. But in fact, often that can be a starter episode for binge eating. In clinical populations, people who are already being seen for treatment, we find that binge eating disorder occurs in about 5 to 10% of a clinical population. Compare that to bulimia, where it's closer to 2 to 3%. However, when we look at population studies, we actually find a much higher rate of these behaviors. In other words, people who've never sought treatment. And it's expected that binge eating in the general population may be as high as 3 to 5% of the general population. But you notice I put exclamation points and question marks behind it. The general population for bulimia is likely to be as high as 3 to 5% as well. But there are certain times when people appear to be at very high risk for engaging in binge eating and bulimic behaviors. And this is particularly true for women in college. And one of the things we found through different surveys that look at both eating and drinking behaviors is that binge eating and binge drinking appear to go together, and that binge eating and purging behaviors exist in extraordinarily high rates on college campuses among women. There are some studies that suggest that the high rates in college may be as high as 60% of females actually engaging in at least one binge eating and purging episode in their first year at university. 60% isn't a disorder. It's not even below average. And so we need to know that these behaviors exist and that they are actually in some places socially sanctioned or acceptable. And we need to begin to think about what we're going to do with this. Now, one of the things that's really lovely is it used to be you either met criteria for this disorder or you didn't. Now, the way that disorders are structured and set up, we actually can diagnose you with bulimia nervosa of a low frequency or duration, or binge eating disorder of low frequency and duration. And I think this is really a nod to the fact that these behaviors by themselves are very concerning. And so if you don't meet the criteria to meet for full diagnosis, we can diagnose you with a sub-threshold level of disorder. We don't have research on binge eating disorder, but we know that sub-threshold bulimia is associated with the same medical risks and consequences as full-blown bulimia nervosa in children and adolescents. In other words, there's not a safe level of engaging in maladaptive compensatory behaviors. And if you think that these are going on for someone that you care about, it's very important to intervene as quickly as we can. So if you think someone has a difficulty, what do we do about it? We happen to be very fortunate because there are several treatments that are known to be effective for bulimia nervosa and to some extent for binge eating disorder. And to the best of my ability, I'm going to talk about for children and adolescents, but some of this data is actually pulled from adults because what we know is that there are 3 types of treatment that appear to be effective for people with binge eating and bulimia nervosa. I'm going to talk about bulimia nervosa first, and I'm going to throw a whole bunch of 3-letter acronyms at you, and I apologize because they all start to sound the same after a little while. We know that both individual and family approaches work for bulimia nervosa. The therapy approaches that are individual are cognitive behavioral therapy and dialectical behavior therapy. Cognitive behavioral therapy has been studied in adolescents, young adults, and adults. Dialectical behavior therapy has been studied in young adults and adults. And let me clarify my terms. Did you know that being a teenager goes all the way up until you're 24? So congratulations, some of you might even still be teenagers. And if no matter what, you're closer to it than you thought you would be. Where young adulthood is generally considered the period from about 18 to 24, and now there's some efforts to push it to about age 26 because, quite frankly, nobody's really all that independent before age 26 these days. And if you can still get covered by your parents' insurance, you're probably still a young adult. Family-based therapy has only been studied in adolescents, and it's really not a treatment that we generally do with young adults and adults who are out of the home and away from their families, but it can be utilized with some modifications for young adults. It just simply hasn't been studied. So even though I presented them with individual and then family, I'm actually going to talk about them the other way around. What is family-based therapy? Family-based therapy for bulimia nervosa is a very pragmatic treatment. Our goal is actually to intervene with symptoms, and so the initial focus of the treatment is all on symptoms. And it assumes that the adolescent is not in control of their eating. In fact, by definition, with bulimia nervosa and binge eating, you're experiencing a loss of control and therefore not able to manage your own eating behaviors. And the treatment actually aims to put parents in charge of those behaviors, to move it so that parents are taking control over the adolescent's eating. And I want to be very specific here, over the adolescent's eating. Nobody really wants to be in control of their adolescent's social life. You might think you do, but for sure you really don't. You don't really want to be in control of their homework either. So it's a very narrow focused therapy. And the goal on symptoms is to first focus on meal normalization. One of the gravest mistakes that we make when people are binging and purging is to assume that if they're binging and they're not throwing it up, or even if they are, to wait a long time until they're no longer hungry in order to eat again. But in fact, one of the best things for treatment is meal normalization, eating 3 meals and 2 to 3 snacks a day at regular intervals, regardless of whether or not you have breakthrough binge eating or purging behaviors. Normalizing your eating in some studies can attenuate symptoms of bulimia by as much as 60%. So just having regular food. The other thing that we do is we put parents in charge of interfering with purging behaviors or other types of maladaptive behaviors. We might ask parents to monitor their teenagers after meals for an hour or more in order to prevent them from going to the bathroom, prevent excessive exercise. We may ask parents or loved ones to go through their room and remove diet pills, laxatives, or herbal supplements. We may have parents help identify some of the behaviors that are interfering in regular eating and help right that system. The other thing parents can do, or loved ones if they're involved, is actually make it harder to engage in binges. And someone just told me the other day that they use this as a sales technique for selling Girl Scout cookies, because one of the things that I talk about a lot is we almost all have foods that if we start eating them, we can't stop. And one of mine is Thin Mint Girl Scout cookies that are in the freezer. If they're room temperature, they could sit there for 4 years and I wouldn't touch them. But there's something about them being in the freezer where they're like crisp and cold and minty and this is why I don't buy Girl Scout cookies. If I eat them, I will keep going back and getting them over and over and over again. And if someone brings them into my house, which they better not do, I will eat them even if they belong to them. So one of the strategies is actually to take away foods that trigger a binge. Another strategy is actually once we start binging, we're likely to binge on high carbohydrate, sweet, rich foods that are readily available. The one that always comes to my mind is cereal. Right? Cereal comes in really big boxes. It's really easy to eat. I wish I could tell you how many of my patients binge on Honey Bunches of Oats. Seems to be really quite popular binge food. If you can just take one box and continue to eat it without stopping or without any cues that you've reached a place of limitation, then it's very easy in a loss of control episode to keep going through it. So we start to create artificial barriers, such as putting your cereal in serving size containers so that each time you're going to have one, you have to stop, and open a container again. You have to actually interfere or stop your eating behavior to engage in another opening, or it creates a little cognitive stop period. So you can see that families can be quite effective in this way. And we know that families can and must really help patients because the family actually has skills to bring. Parents, loved siblings, they know the patient better than anybody else. They're there and they're observing and they're experts in that. So the therapist in FBT is really leveraging parental skills and relationships to bring about change. And everyone is working together to combat this illness. It's really lovely because parents and children, when bulimia nervosa is in the picture, often are more collaborative than, say, with anorexia nervosa. Patients can often identify what they have trouble with. So in the first phase, what we're doing is we're raising parental anxiety to act. We're disrupting maladaptive eating patterns. We're identifying things that put you at risk for engaging in these maladaptive behaviors. FYI, being really tired or being really hungry, those are both huge triggers for binge eating behaviors. And we really do parent-directed replacement with healthy behaviors. Bulimia nervosa is a very collaborative treatment. But of course, parents shouldn't be in charge of everything for a very long time. So in the second phase of treatment, we're really working for parents to hand back that control to the adolescent. And there's a slow process of emphasizing a maintenance of secured skills. In other words, you're doing breakfast and you never binge at breakfast and you seem to be doing really well with that. So you're going to get to do breakfast kind of on your own and unmonitored. We'll drop you off at school. And I wrote continued weight gain, but actually that should be continued weight maintenance. I apologize for that. I don't know why I didn't catch that. What we are not trying to do is lose weight. This is not a weight loss therapy, nor are the treatments for binge eating disorder. We do not want people dieting because dieting holds in place all of the things that set you up to develop these disorders. And there's an emphasis throughout the second phase of therapy on finding other behaviors of eating in normalized settings. So people eat out and learning how to eat and control your portions when they may be higher than or larger than you might typically serve yourself or you don't know what's in them. The other thing we do is supplement behaviors that may cause binge eating and create rewards for things that are not food-based. And that continues throughout phase 3. The third phase of this treatment, the patient is either weight restored or weight maintained, and they're having more typical thoughts. They're thinking about their body image, weight, and shape are more in line with the rest of us. In other words, I'm overweight, but it doesn't actually stop me from doing anything. I wear the clothes that I want to wear, I wear bathing suits, I go swimming, I do all sorts of things. I'm not waiting until my body looks a certain way or feels a certain way to engage in these activities. I may learn to like certain things about my body. And then we also focus on relapse prevention because we know these disorders have a very high risk of relapse. And the reason why is very clear. You will never in your life be able to go without eating. And so securing these skills in a variety of different situations, right? Eating at home, eating out with friends, eating in a cafeteria, eating when you're at work. We recognize that there are lots of areas where there may be risks for relapse. And then we also restore typical family functioning. We've scared parents to death about the risks of these disorders, and I'm going to let Dr. Aggarwal do that for you. And so once we've scared you to death, it's really hard to lower your anxiety about the types of risks of these behaviors. And we also want to restore typical adolescent functioning. Now, what does cognitive behavioral therapy look like? Interestingly, it's the same as I'm sorry, let me finish with family-based therapy. The outcomes are the same as they are for cognitive behavioral therapy, which I'll talk about in a second, but it's more efficient. Change happens faster. We get faster cessation of binge eating and purging behaviors in family-based therapy than we do in cognitive behavioral therapy. But before we get too excited, we're talking about 3 studies ever. Bulimia nervosa in children and adolescents is probably one of the worst studied disorders. There have been very few comprehensive treatment studies that have been done of outpatient therapy. And of them, Stanford and University of Chicago Collaborative Group have published 3 of the 5 total studies that are out there. So what do we do for individual treatment? all of those things that I just said happen in family-based therapy, where parents might be managing it, happen in cognitive behavioral therapy, but it involves the individual, the patient, him or herself, being the one who's monitoring diet, feelings, conflicts, and the things that lead up to binge-purge cycles. So the targets are the same. We want to normalize eating. We want to undo thoughts around the body image, shape, and weight, and ideas around food. But rather than having families step in and do this, we increase monitoring for the individual. We get them to pay attention to their thinking. And just like in family-based therapy, there are 3 phases of treatment, and the phases actually map very well onto FBT. Where in the first phase, we're educating and normalizing eating. We're really emphasizing the importance of paying attention to what you're eating, when you're eating, how you're eating, who you're eating with. And this is going to sound a little odd, but the emotional and social circumstances under which you're eating and how high your urges to engage in maladaptive behaviors are. In phase 2, when we've had some normalization and reduction in symptoms, we start to pay attention to both food and emotion triggers. We want to actually stop you from engaging in these behaviors before they even begin. It's sort of what you might think of as risk management. But associated with that, we're also exposing you to feared foods. So if I was going through this therapy, someone would actually make me eat Thin Mints that had been in the freezer and not let me overeat on them. I'd like to see who could manage me doing that, but actually I'm pretty sure people could do it. So we want to make sure that people aren't living their lives with feared foods, that they don't look at foods as good or bad, because actually food is food. But you might have foods that you might be more selective with when you eat them or how much you eat of them. And finally, in the third phase, just like family-based therapy, it's development of interpersonal skills, resilience skills, management skills for going out into the world and actually having a life worth living, and the things that supplement or overcome the risk for binge eating. And so because I know that I'm running a little bit over, I'm going to sort of quickly push past these. These are the things that I was just saying, but it was faster for me to say them. Now, DBT is something different. How many of you have heard of dialectical behavior therapy before? Okay, a couple of people. Dialectical behavior therapy really looks at treatment a little bit differently. It says that at the core of it, most of us are experiencing what we're going to call maladaptive emotion regulation skills. In other words, how do I control my emotions in a way that makes me effective, useful, motivated, and more constant? And so what we're doing in DBT for binge eating and bulimia is really looking at these emotion regulation skills. We're trying to figure out how your emotions may drive certain behaviors, and where we might use food logging, write down what you're actually eating, DBT uses something called a chain analysis, which starts with your emotions. I was giving a talk and I was feeling kind of nervous, and I was thinking, oh, I need to reward myself, and what kind of reward could I come up with? And it was chocolate, and then I went home and there was a lot of chocolate and I was feeling really stressed out. You're tying emotions and emotion regulation back into this. DBT was originally created for use with people who engage in self-injurious and suicidal behaviors, and because those self-injurious behaviors co-occur with bulimia nervosa fairly frequently, they're relatively highly comorbid, DBT was really thought of as a treatment that could address both sets of behaviors at the same time. And it views that binge-purge cycle as part of a dysregulated emotions. It's important to note that the longer that we engage in binge eating and purging behaviors, the more purging behaviors become uncoupled from food and eating. In fact, where you might start off purging because you were binging, over time what we often see is people start purging for its emotion regulation capacity. This is hard to believe because very few of us engage in self-induced vomiting, and most of the time when we do vomit, it's because we feel badly. But even you might notice that if you've been feeling ill and you throw up, you feel better for about 20 minutes. If your mood is stable and you induce vomiting, it will actually improve your mood. It will heighten your mood. It will make you feel good. It's like hitting an emotional reset button. and that lasts for about 20 to 30 minutes. And so we know that one of the things that we have to target in treatment is the ways in which our biology can become addicted to hitting the reset button that is purging behaviors. And DBT takes that track as primary, where CBT and family-based take that as secondary. So this is beneficial even without a focus on food for some people who may have more dysregulated emotions. Fortunately, we can also use medications, although we rarely, if ever, use medications alone. So we've studied the use of Prozac or fluoxetine, and we find that in high doses, these are quite high, an average dose for something such as depression would be about 20 milligrams. In very high doses, SSRIs may be useful. And they are FDA approved, or several of them are, for use in bulimia nervosa. So they're labeled for this use. And its efficacy or its action is independent of depression or anxiety. So even if you're not experiencing depression or anxiety symptoms, high doses of SSRIs may actually attenuate binge eating episodes. And these studies have been done in adults and older adolescents or young adults, not in teenagers under the age of 18, although it has been used for that use. The thing is that we don't use these medications alone. The first step is always psychotherapy, and generally psychotherapy for 6 months or more in order to get control of symptoms. We really use the SSRIs when we're having a hard time getting all of the symptoms under control because they present their very own risks. Binge eating disorder treatment is fairly limited. We know very little about effective binge eating disorder treatment in children and adolescents. Even though it was only added as a disorder recently, there are actually more therapy studies for binge eating disorder in adults and young adults than there are for bulimia and anorexia, actually more than for bulimia and anorexia combined. And the studies that we have focused almost solely on adults and young adults. So what I'm going to talk about here are not specific to children and adolescents, although there are very good reasons to believe that these treatments would be effective. And so the two individual approaches that we talk about are CBT and DBT, exactly as I've described them for bulimia nervosa, only instead of focusing on purging behaviors, we simply are focusing on the things that lead up to binge eating behaviors. Again, CBT would probably be considered the gold standard, but not well studied in children and adolescents at all. And there really aren't randomized clinical trials. So I can say that we've used these treatments and they've been effective, but I can't really point you toward the science to say that this is empirically supported. We know that there's some future research for these. There are some ongoing studies now looking at DBT both in group and individual practice for patients with bulimia nervosa, as well as IPT, which stands for interpersonal psychotherapy. There's one study that was done looking at group cognitive behavioral versus group interpersonal psychotherapy for adolescents, and they actually were equally effective. And interpersonal psychotherapy, learning how to relate and interact with other people, managing interpersonal skills, managing interpersonal emotions, actually gave better relapse prevention than cognitive behavioral therapy. So it's been started to be moved into these treatments in something that's sometimes called CBT enhanced, which is really just saying we stole parts of the other treatment that worked really well and put them into ours. But that's okay because that's actually good science. We do know that there are other adjunctive treatments that sometimes people use, like art therapy, emotion therapy, and movement therapy, but these have never been studied, especially not in children and adolescents. And there are programs that use hospital, inpatient, partial hospitalization programs, but also these are not as well studied. Pharmacologically, there are ongoing studies looking at SSRIs as well as the atypical antipsychotics for some people with bulimia and binge eating. But the atypical antipsychotics have the side effect of causing weight gain in some groups, certainly not all. And they can also lower your seizure threshold, as does purging behaviors, so sometimes there's some risk for that. What's on tap for bulimia, for binge eating disorder? We need to study all of it. There are studies being done looking at all of these treatments right now because it's increasingly being identified as a problem and a challenge that has major medical and psychological risk factors. So this is me, if anyone needs to reach me, and I will happily hand this over to Dr. Aggarwal.
Aggarwal. I'm one of the adolescent faculty here, so I'm in the Division of Adolescent and Young Adult Medicine, and I am the medical piece of what we're going to be talking about this evening. So just a brief sort of outline in reference to the things that we'll go over. Adolescent development, I think it's really key to look at the foundation of development when you think about adolescents and young adults. How does that influence what happens next in reference to something like bulimia or binge eating disorder? How does it influence illness, essentially, in an adolescent and a young adult? We'll talk a little bit, obviously, about bulimia and binge eating disorder, what happens to the body, and what does this mean in terms of caring for your teen. So adolescence is a very dynamic time. We've all been there, and we all know that it's a complex time of change. It's a complex time of biological change. You're going through puberty, you're starting puberty, you're progressing through puberty, you're completing puberty. You're learning how to think about things in more complex ways. If you think about your own child or when you were a child yourself, the way you thought about things when you were 8 as compared to 12, as compared to 17, as compared to 21. These were very different ways in which you thought about the same information. And this is very much related to the biology of your body, the growth and development of your body and your brain. So this is very much embedded in the science of your body, if you will. Now, psychosocially, what that means is in terms of how did you interact with your peers? How did you engage with your environment? How did you engage with your parents and the adults around you? This is also a moving target, if you will, during your adolescent years. This changes as your body grows, as your thoughts change, as your mind changes over time. So when we think about adolescence, we want to think about this dynamic model of progressive change. The next few slides are looking at how we split up the concept of adolescent development. We think about it in a couple of different ways. We think about early, middle, and late. And this is probably just pay more attention to the pictures than anything in reference to thinking about a group of individuals in this age. When you're a young adolescent, the ages, potentially in these ages, you're a more concrete thinker, you're a more black and white thinker. Things can be either very good or very bad. And sometimes having a gray zone can be a little bit more challenging to conceptualize, to really wrap your mind around during this particular time. So it's very normal to think about who you are. Am I normal? Am I not normal? Is this good? Is this bad? So that's more typical for early adolescence. If you think about your middle adolescent years, more during the ages of like 14 to 17. This is kind of an evolving time period. You're progressing through puberty, potentially completing a lot of pubertal development, thinking about, once again, who am I as a person? What are my beliefs? We think of this as a time with increased risk-taking behaviors, and we're going to talk a little bit more about that as we explore what does it mean to be a teenager and what does it mean to be a teenager who has bulimia or binge eating disorder in the medical context of things. Oftentimes identifying with peers in reference to what is normal, fashion, hair. The way I think about this is everybody's trying to be different by looking the same, right? So that is a very common thing for adolescent development. If you think about late adolescence, then you're thinking about more of your young adult years, and as Dr. Fitzpatrick mentioned, as we're understanding more and more about what does development look like for a teenager and young adult, we're finding that really your adolescent years stay until your mid-20s. And that really is related to the concept of brain development, which we'll also talk about, and how that informs certain ideas about decision making. So this is progressing in terms of who am I going to be in the world? What are my beliefs? Potentially realigning with parental norms. We think of adolescence as a very conflicted time in terms of having a lot of conflict with parents. And that's the most common thing people think of, right? But in general, most teens tend to get along with parents. But these are some common ideas that we have about being a teenager. I wanted to introduce some ideas about the brain and progress and highlight some of what Dr. Fitzpatrick said in reference to how does this influence adolescent decision making. The adolescent brain is changing. During your teen years, we have this progressive development from being a more concrete to a more abstract thinker. That is very much embedded in the science of your body. The brain is going through a fine-tuning process, if you will, in reference to more complex thought. Some of the areas that are more linked to, let's say, more emotional thinking potentially develop a little sooner than the areas that are linked more to more executive functioning, or what we think of as rational thinking, right? Now, does that mean that teenagers are irrational, that they're just naturally impulsive? We associate these ideas with them, but in reality, that isn't always the case. We know through various pieces of science, through research, that teenagers in many ways can assess risk very similarly to adults. When you give them certain tasks, they're able to evaluate it in a way that is very similar to their adult peer who might be given the same task. But what we're finding is that their value of the reward of the task could potentially be skewed. And this is very much embedded in the reward system, the neuroscience of the body. So there is some thought then when we get a positive stimulus, we as adults react to it. Teens may have a more significant neurochemical reaction through the reward system, through the dopamine system, than the adult, right? So going to that party where Tim is going to be, that mom and dad really don't like him, and it's probably not a good idea, I really shouldn't go, but it'll be so much fun, right? The value on the reward is skewed, even though the risk assessment of what you're doing may potentially be there. So this is on the heels of what Dr. Fitzpatrick was saying. When someone purges, it could feel good for about the next 20 minutes or so, right? So it's not that a teen may not be able to wrap their mind around the fact that I shouldn't purge. I know this is harmful. I know my doctor told me I shouldn't. I know my therapist said that, hey, this is potentially really harmful, and these behaviors build on themselves and they become more difficult to break over time. They've heard that information. But I'm going to feel better once I purge could outweigh the I shouldn't do it, or I know I shouldn't. Now you wrap that around the subsequent feelings of guilt. I just did something I shouldn't, and it becomes a vicious cycle. But some of that need to purge could very much be embedded in the science of the body. That's one of the ways in which I think about it. So it's really important to understand that it's not that teens are making reckless decisions, but their ability to kind of weigh the risk benefit of it, or the fact that I will feel better, may be skewed in one direction. So, eating disorders and medical complications. This is a broad concept that I want to highlight. And the gist of this, the way in which I think about this, is as in nature, the body will try and find balance, right? So that is what the body is seeking. And when we have dysregulated behaviors, the body will try and compensate for those dysregulated behaviors. Now, the compensation, depending on how dysregulated the behaviors, may not be enough. And this is when we start getting into a slippery slope and dangerous territory in reference to how does your body manage that dysregulation. And we're going to go into some of the details around that. So, the body will conserve energy. I use a lot of analogies. So this is one of the analogies I use of the car and gasoline, right? If you think about the fact that when the system is dysregulated, it's going to go into survival response. That's essentially the way to think about it in terms of the science of your body. What do you need to make a car run? Gasoline, right? We're not talking about electrics or hybrids. You need gasoline. What happens if you don't give the car gasoline? It uses what it had, slows down, eventually will stop. What if you give the car gasoline, take it away? Give the car gasoline, take it away. What if what does that do to the efficiency of that car? It's not going to be as efficient a car. The body is very similar in that way. Your metabolism is essentially the engine of your body, right? Food is really the fuel. It is the energy with which your engine runs. When a well-fed engine works best, right? When you have an engine that is not being properly fed, when you have a body that is not being properly fed, when you have food that's being put in and taken out, that affects the metabolism and actually slows the metabolism of the body. So one of the consequences over time of particularly bulimia despite the fact that the adolescent or young adult may be motivated to lose weight, they might have a drive for thinness, they might want a lean body type, is in fact weight gain, because the metabolism of the body is in fact more likely to slow than become more efficient. And this is something that is very hard for an adolescent to understand, because once again, it's an immediate sort of approach. I've eaten too much. I feel really badly about this. I need to do something to feel better and potentially to achieve my goal of being thin. And therefore, there can be purging behaviors. So we explain that principle in terms of the metabolism and the potential slowing and the fact that you're actually being counterproductive to the goal that you want. But it sometimes needs to be explained multiple times in reference to somebody really being able to wrap their mind around that. That slowing response of the body, what does that mean? Right? Anytime something slows, it's going to quiet down. That's the way I think about it. So how do we see that in the system? We see it through lower heart rates. We see it through lower blood pressures. We see it through lower temperatures. These are all mechanisms by which the body tries to conserve energy. Right? You don't have consistent energy in a way that is sustainable for the system. The system is going to try and survive the best that it can. It will try and conserve energy. So in that survival mode, it will also try and prioritize certain organ systems, the brain, the heart. Adolescents will often tell you, depending on how much energy they're taking in, depending on their degree of malnutrition. Malnutrition is the umbrella term that we're using here. They feel cold. Their hands and feet can feel cold. That is the body prioritizing certain organs as opposed to getting as much blood out to the hands and the feet, right? That's one way in which it shows up in reference to the science of your body. If your body is not consistently getting nutrition, it's not going to prioritize growth and development, right? So if we think about an adolescent who is a 12-year-old and you think about a 19, 20-year-old adolescent, there's a significant amount of growth that's happened during that time period. And one of the analogies I use for that is you're building the house you're going to live in. So you're building a lot of your bone density during that time. You're building your organs. You're building the body that you're going to carry with you into adult life. So this is a really key growth time in reference to getting the nutrition that you need, so you build a strong foundation that you then carry with you into adult life. And if you're not building that strong foundation, you're more likely to have complications, not just as a teenager, but then also in adulthood. I won't go over this because Dr. Fitzpatrick already reviewed some of that. So we'll talk about complications with bulimia. I put this slide up front because for teens and young adults, more immediate consequences, more visual consequences may be more impactful. Talking about things such as your skin, having unhealthy skin, if you will. You can have dry skin and hair. Skin is our largest organ. A healthy body is going to demonstrate healthy skin. So people can oftentimes, once again, first things we'll see is dry hair, dry skin, hair loss over time. You need a well-nourished body in order to grow hair. People can appear tired, they can appear pale. I mentioned this last thing called Russell's sign. It's a medical term. And what that is sometimes adolescents use their hands to help them to purge. And by purging, I mean vomiting, although Dr. Fitzpatrick also mentioned different methods of purging, which include the use of laxatives or diuretics, or even exercise, right? But in this context, what I mean when I say purging is vomiting. And what sometimes can happen is if you're repeatedly using your hand to induce vomiting, you can get scars and abrasions on your fingers and your knuckles. And so this is one of the signs that we might see with the teenager or a young adult who's struggling with this illness, that they have these abrasions and scars or thickened skin. And we call that Russell's sign. So I've got some pictures. Obviously, as you can see, some of them are cartoons and some of them are just regular pictures in an effort to explain some of the things that we worry about. We're going to talk about the gastrointestinal tract, the GI tract. We'll just call it the GI tract. In reference to why do we worry about certain medical complications with in the context of bulimia. So our GI tract extends from our mouth all the way down to our rectum. And we're going to think about and talk about what are the complications that we worry about when we have someone who is vomiting and bringing up the stomach acids that should be housed in our stomach. Let me just go back to this picture for just 1 second. So if you think about the mouth, the esophagus, the tube that carries food into our stomach, and then this essentially communicates with our intestines, and we have our small intestine or large intestine, and eventually where we stool through our rectum. Just to give you a sense of what are we talking about here. In the mouth, if you are vomiting repeatedly, it's not uncommon that people will have inflammation at the back of their throat and potentially a sore throat. Sometimes they can have red dots from the pressure of vomiting repeatedly. So this is something that we can see. Swollen glands is often something else that we see. If you've ever eaten something really tart, you've probably had that reaction where you have the release of some saliva in your mouth, right? We've all had that experience. That is your salivary glands and your parotid glands. That's those glands working to help you digest the food that you've put in your mouth. And those glands kick in anytime we eat. These glands, when they're repeatedly stimulated, potentially through the action of purging, can enlarge over time. So this diagram right here basically shows the parotid gland in particular that we see sometimes gets larger and can feel occasionally painful and tender for the adolescent, gets swollen essentially. How does that show up in reference to if you're concerned that there's behaviors that you're potentially seeing that you want to you want to see whether or not is this worsening, is there potentially purging? You might notice that there are changes in the facial structure of the young person that you're working with. You might notice that they're getting a little bit more swollen around their jawline. That could suggest that these glands are potentially getting a little bit more swollen. Tooth decay is something that we commonly see. If you think about, once again, the stomach acids being brought up into the mouth repeatedly, it can wear on the enamel of the teeth. You can get yellowing and tooth sensitivity over time because you're wearing off of the enamel layer. Interestingly enough, in binge eating disorder as well, you can have an increased risk for tooth decay also, because if you're binging on some of the foods that Dr. Fitzpatrick described, particularly sugary foods, high carbohydrate foods, that increases your propensity for tooth decay. So this is something that we can see in terms of increased risk for cavities, caries, gingivitis, all those sorts of things with someone who is struggling with binge eating disorder, and then with bulimia in reference to enamel erosion. Excuse me. Bad breath is also something else that is commonly, that can be something that is commonly seen. This might be more impressive for an adolescent to hear something like, this is something that could cause bad breath. This is something that could make your teeth a little bit more sensitive. Potentially those longer term consequences, such as this could have an impact on your development, this could have an impact on kind of future consequences for you. Those things might not register as much with a teen, but whereas we're talking about something like, hey, your skin might not look as healthy, or your teeth might turn yellow, or your breath might not smell good, these potentially are things that could be more impactful for your teen. So this is just highlighting some more of the GI tract issues. This is a little snippet of that connection between the stomach and the esophagus. The skin in our mouth is very similar to the skin in our esophagus, which is different than the skin in our stomach. The skin in our stomach is thicker. It's used to having the stomach acids, which are basically a more complex fluid, if you will. The skin in our mouth and our esophagus is not designed to be exposed to that stomach acid for an extended period of time or repeatedly. So when we do have the gentle skin of our mouth and our stomach repeated, or the esophagus repeatedly exposed, it can lead to damage to that skin over time. And the force with which sometimes adolescents or young adults they purge or vomit, making themselves throw up, can lead to tissue damage as well. Might lead to tears, and we worry about them bleeding as a result of these tears. Sometimes the tears can be small, sometimes the tears can be large, and we are concerned that that might lead to bleeding depending on the degree of that tearing that happens with that gentle skin that is being repeatedly exposed. Acid reflux, the discomfort that's associated with that, GI pain, potentially chest discomfort or pain, these are things that people can complain of. So these are some of the things that we think about in reference to the GI complications. In reference to how do these things influence the heart, dehydration is a concept that influences general well-being, but then also potentially could influence the heart as well. You can lose fluids when you're purging. You can vomit an excess amount of fluids. If you're using something like a diuretic or a laxative, you can pee out or stool out a large amount of fluid. This can lead to dehydration. That is going to lead to weakness, potentially for an adolescent. That could also lead to changes in their heart rate, in their blood pressure. And these are things that we consider when we check their heart rates and blood pressures when they come into our clinic. If you think about how your heart works when you're lying down, it doesn't have to work as hard to get blood to your head, to your feet, back to your heart. Now, if you think about how your heart works when you sit up, works a little bit harder to get blood up, down, and back. Now you stand up, it's working even harder, getting blood to your feet, getting blood to your brain, getting it back, circulating it in different parts of your body. If you're otherwise healthy, the body should be able to make an adjustment in your heart rate and blood pressure within a reasonable range to where you don't feel dizzy, where you don't feel wobbly. You're able to get up from a seated position. You're able to get up from out of bed and not really feel badly, not feel, once again, dizzy or so. When your system is weakened, right, let's say potentially you're dehydrated, you're not eating in an appropriate manner, your body is going to be weakened, and your heart isn't able to make those adjustments in that reasonable range, right? So your blood flow changes to your brain. That is going to be felt by the individual. That could be felt as dizziness. We worry about somebody passing out as a result of that. So this is an important marker in reference to the well-being of the body. Can the heart make an adjustment in reference to the heart rate and blood pressure in a safe way when you're doing different activities? So one of the other things we talk about is loss of electrolytes, especially potassium. So electrolytes, the word I use for it is salts. We have certain important salts in our body that essentially help our body to work well. When we have dysfunction, what happens with that is that we can have a shifting in these salts. When we have somebody who is purging or using a diuretic or using a laxative, it changes the balance of these salts. These salts are very important for our heart to beat well. They're very important for even for our cells to work well. So we worry about how having low levels of certain salts could lead to dysfunction in reference to how your heart is beating. A broad concept to think about is, once again, that quieting response and how does the body adjust to increased energy demands, right? So I included something here in reference to cardiac output, exercise capacity. Oftentimes, young people can be very motivated to be very active. If they're not feeding the engine of their body to support that level of activity, their body's going to get more and more depleted. So that's a really important thing to keep in mind in reference to, first of all, not having enough nutrition to support basic function, right? And then secondly, overexerting the body and the impact that could have in reference to collapsing, or in reference to feeling fatigued, in reference to the heart not being able to tolerate stress or intensity in reference to excess activity. This is also, once again, broad concepts, and on the heels of what Dr. Fitzpatrick was talking about, cognitive changes. How are you thinking when you're depleted? I'm sure everybody's had the experience of being tired, not getting enough sleep, maybe having a day where you weren't able to eat as well as you would have otherwise liked to. By the end of that day, you probably were, not able to do much more because you hadn't nourished and taken care of your system. So if you think about this happening on a regular basis, people aren't necessarily going to feel well and think well. And you could have slowed thinking. We talk about stuck thinking. One of the things that we frequently see is when adolescents, when they're not eating well, when they're not taking care of their system, they tend to ruminate more on certain thoughts and behaviors related to their dysfunctional eating. They tend to be more stuck in it when they're not consistently nourishing their body. And what we've oftentimes seen is you have to have a certain threshold of consistent nutrition, maybe even consistent weight, before adolescents are able to move beyond that stuck sort of thinking. So that's an important thing to keep in mind. We mentioned the distortions in reference to self-assessment of weight and shape. Once again, if your body's more depleted, are you even going to have the energy to challenge some of these thoughts that could be coming up for you? So this is embedded in the science of your body, if you will. So there's a lot of systemic effects that can happen with the body, and I just included this because I thought it was an easy sort of diagrammatic approach in reference to some of the things that we've already talked about, and looking at the various impacts that could happen with the body. One of the other things that I didn't mention is something that's present in the corner here, which is hormones. This is, if you think about it most intuitively, does it make sense for the body to lose blood if it doesn't have the nutrition in order to replace and replete those cells? It really doesn't. Body goes into protective or survival mode. How does it do that? It does that by trying to quiet that system down and shut it off, essentially. We do that by quieting down the hormones that help us to get periods, or the hormones that help with pubertal development. Those same hormones that help with pubertal development and periods are the hormones that also help us to build strong bones. So irregular cycles, irregular periods, irregularity in these sense, once again, are a marker for imbalance in the body. This, of course, has the short-term consequences of suggesting the imbalance and the impact, and then, of course, long-term consequences. The longer malnutrition goes on, the more of an impact it's likely to have on the system. And there are some studies to suggest that bulimia, in particular, in reference to reproductive health in the future, that it impacts that, and it could be related to hormone irregularity, but then also just the chronic effects of malnutrition. So this is just an important concept to be aware of. So in terms of binge eating disorder, we've brought in some concepts in reference to that as we've been talking about bulimia. Binge eating disorder, the medical complications of this are really very similar to the disorders related with clinical obesity, although not all individuals who have binge eating disorder are overweight. But if you think about what are the complications with this, oftentimes we see lipid abnormalities, which are high cholesterol or high triglycerides. This could be related from maladaptive eating habits. We see risks of high blood pressure, risks for diabetes. Obstructive sleep apnea, essentially, this is something that's more related to weight for individuals, and once again, very similar to the complications related to clinical obesity. Potential vitamin deficiencies, despite the fact that someone may be binging on large volumes of food, it doesn't necessarily mean that they're getting the nutrients that they need in order for their body to work well. So people can have vitamin deficiencies despite the fact that they may feel like they're eating excessively. Based on weight related to binge eating disorder, people could have stress on their joints. We talked about problems with menses and infertility in reference to irregularity of the bodies. Irregularity in terms of the body function. And people who suffer with binge eating disorder can also have increased symptoms of irritable bowel syndrome, fibromyalgia, insomnia. One of the concepts that I talk about frequently is we all think about how we need nutrition in order to run, in order to be physically active. But in reality, you also need nutrition in order for your brain to work well and for you to sleep well. Right? So sleep dysregulation is something that we commonly see in disordered eating and eating disorders because your brain is not getting the nutrition in order to be able to sleep well. So this is something that I frequently tell parents and tell teens, because a lot of time people complain of the fact that they're not able to fall asleep, that they're waking up, or that they just don't have restful sleep. And there's a lot of complex nuances in reference to sleep, in terms of how stress affects the system. But nutrition is a key piece of once again, your body staying in balance and working well, and also regulating your sleep. So these are some of the concepts in reference to bulimia and binge eating disorder in terms of the medical complications. And we can certainly talk more about it as we talk about the questions section. Right. Thank you.